Welcome back to ACCEL for July 2010. First up on Disc 3 is a conversation between Dick Conti and Dr. John Criley, Emeritus Professor of Medicine at Harbor-UCLA Medical Center, on a back-to-basics approach to the bedside physical assessment.
Now, I know you've given a talk on this subject, so why don't you tell us what you told the audience about bedside physical assessment?
Well, what I believe is that bedside physical assessment is a multimedia experience. By that I mean that there's something there that you get from the patient's history, there's something that you get from seeing the patient, from putting your stethoscope on the patient, and most importantly, while you have your stethoscope on the patient, observing the pulsations that might be present in the jugular vein or the carotid artery or the precordium that can help you time the events that you hear. And then we're also have discussed the maneuvers that you could put patients through when there's a differential diagnosis at the end of your exam. Let's say we have a mid-late systolic murmur, and then you say, well, could that be mitral prolapse or hypertrophic cardiomyopathy? Well, you can put them through maneuvers and have them stand and squat. Well, that's a situation where you can enhance the murmur of either of these conditions when the patient stands after coming out of a squatting position, and can diminish the murmur intensity and actually shove it later into systole by squatting. And then if you then put that information together with one simple test, namely the electrocardiogram, if it's a hypertroph, he's going to have big time LVH. Right. If it's a prolapse, probably a normal electrocardiogram, maybe a long QT, but rarely are you going to see the kind of LVH that you would see with a hypertroph.
So what you're telling me is this is more than just listening to the heart. It's a lot of other things, and including the electrocardiogram, I assume the chest X-ray as well.
Correct.
And other, which can be very sophisticated stuff.
Yes, and if you go at it one-dimensionally, let's say you're looking at your patient as an X-ray, or you're looking at your patient as a electrocardiogram, and ignoring the other attributes to that patient's presentation, you can go off. I was telling you earlier the sad story of a young man that came in with gross bright red blood hemoptysis and the inability to lie down for over 6 months. He was admitted many times to our hospital with this hemoptysis. He underwent every pulmonary test you can possibly think of, including gastric cultures for tuberculosis, bronchial biopsies, lung biopsies, and finally the pathologist, the surgical pathologist, looked at the slide from the lung biopsy and said, Masson bodies, this guy's got mitral stenosis. Called the house staff and said, this is Dr. French down in pathology, your patient has MS. And they just couldn't understand this. How does he know? But they set the patient up for an echo, and the echo showed that he had a just completely severely stenotic mitral valve. And I was listening to him in the hall outside of the echo room because I heard he was coming. And this guy had a first heart sound that you could hear without a stethoscope, and had an opening snap and a diastolic rumble. And so after he got back to the floor, after this echo, all of the hospital notes said, diastolic murmur heard, and that they didn't know that you're supposed to hear an S1 or an opening snap, so it was just shocking. I looked at his X-ray, and it was beautiful, small heart with a straight left heart border, double density, and all of this crud at his lung bases that has been the blood that had trickled down because he couldn't lie down. It all went to the base. I then got the CT out, and there was lyrical descriptions of what was going on in the lungs, and there was the heart right in the middle of these CTs with a huge left atrium. The right ventricle was just crowding the left ventricle into a little prune, and a calcified mitral valve. And the radiologists didn't see the heart, they just saw the lungs. And they had a differential diagnosis that included miliary tuberculosis, miliary spread of a lymphangitic lesion. And here was this big left atrium and a mitral valve stenosis that was just unbelievable. So we're really talking about the big picture. You like to put, as Proc Harvey would say, the 5 fingers together, the history, the physical, and of course the ECG, the X-ray, and any special tests that are necessary.
Okay, and it also is what Gene Stead said, what this patient needs is a doctor.
Yes.
And not somebody just looking at one piece of the puzzle all over the place. I agree with that. I don't have any problem with that at all. In fact, I'm aspired to try and teach this to the second-year medical students. It's not easy. But by the way, I do use your physiologic assessment of heart sounds and murmurs, and that goes over very, very well with the second-year medical students. It's not like they're sitting in a dark room listening to heart sounds or murmurs. You know, they're seeing the physiology, which I like.
Well, as you know, Dick, when we were young men going through our fellowship, we were taught by masters. I mean, these guys, right, all they had was a stethoscope and an ECG and an X-ray, and we learned a lot from them. And then when X-ray motion pictures came into the scene, Mason Soanes introduced cineangiography to the world of cardiology, and you could see valves move, and you can measure. We were always recording heart sounds in the cath lab with LA and LV pressure and the heart sounds, and we were able to correlate the heart sounds with the motion of the valves, and just got very excited about all of that. And then echo came along after our training was over, and it made it even easier to see what was going on. But then we watched these dissipate from each other. That is to say, the echo was completely separated from the patient's physical exam, so that if you got an echo, you didn't have to do a physical exam. Right. And then pretty soon, instead of learning more by listening to the patient first and then looking at the echo and say, what did I miss, what did I get right, and so on. If there's a hint of a murmur, they'll send a requisition that says, rule out murmur, and the patient reading the echo has no idea what the patient has and just looks at it and gives a TR, MR, PR, AR, and the poor guy back who sent the patient up will say, I didn't hear that TR or the PR, and they don't realize that those things are just color flow and don't necessarily mean anything hemodynamically significant.
Well, I think you put the whole thing in perspective. I tell you what bothers me a little bit. I spend a lot of time on the inpatient cardiology service, half-time, but half-time is 26 weeks out of the year. Yeah. So I'm seeing a lot of people with cardiac problems. And to try and teach physical diagnosis on the ward is becoming almost impossible because lots of things, noise, chest covered up with all kinds of monitoring devices, people in the next bed watching television with 8 relatives. I mean, it's just impossible. And I find that, I tell these folks that the best way to teach this is in the clinic, where I have one patient undressed, so I can listen and it's quiet. It's really a real problem with hospital-based medicine right now in trying to teach this subject.
Yeah, all your patients that are coming in for a catheterization or coming in for open heart surgery are on a slick pathway, and they're on a gurney by the time you get there, and somebody's pushing the gurney toward the operating room, and so you don't really get a chance to listen or teach with that patient. And so it really puts all the teaching in the outpatient department, and that is very good, but the clinics are now so overcrowded that, when I try to be the consultant in clinic, I'm being pulled 15 different ways, and so even that is hard to do.
How are we going to get around it? I mean, I agree with you when you said that, you used, for instance, the echo. Well, yeah. When I trained, the echo was looking for submarines.
That's right.
And then after that, it came along. But to me, I use the echo to try and confirm what I think is going on, and I think that's the way we ought to use every lab test. You agree with that?
I agree, and of course, it is a marvelous technology if the government takes over medicine and they say you can't use echo anymore. I'd go out of medicine because I can't get along without echo. On the other hand, to use echo as the king, and then you don't have to listen to the patient because the echo already gives you the diagnosis. And try as they might, there's a lot of mythology involved with how to calculate the severity of a lesion, or to maybe be sure you can rule out something that is there. And for example, atrial septal defects don't always show up very well on an echocardiogram. RV outflow tract lesions of various types do not show up well on an echo, either transthoracic or transesophageal. And so, again, when you have a patient that has a murmur over the RV outflow tract, is it due to some pathology in the outflow tract or just a lot of flow through the outflow tract? Again, the echo will often let you down. Sure. So again, looking at the big picture, is there something on the x-ray? Is there something on the ECG? As an example, we had a patient that had a non-cardiac complaint, and they took a chest x-ray, and she had this huge post-stenotic dilation of the pulmonary artery. Had to be a tumor, so CTs were done, and this woman had a nice, tight pulmonary stenosis valve. They irradiated her to death trying to find out what this tumor was, and it was just a dilated pulmonary artery